Good morning. Buenos dias. I am Jose Pablo Rojas, CHCI's PepsiCo Health Public Policy Fellow. I am delighted to be with you here today for the opening plenary of CHCI's Health Summit titled The State of American Minority Health and the Future of Health Equity. Cultural awareness, cultural empathy are the prompts in the diversification of the very fabric of our health system. Growing up in the border community, you witness firsthand the inaccessibility of affordable care, the lack of health literacy in non-English speaking communities, the health disparities within communities of color, an unfortunate truth of our circumstance when seeking care in the United States. The systems in place are changing. Look around you. We're all here to seek change. The fight for health equity is strong. I hope for one day that our health system will prompt the authentic expression to the commitment of social justice, respect, access, and dignity that the Latina community deserves. And on behalf of CHCI, I would like to thank Johnson & Johnson, Be The Match, Hentech, Walgreens Boots Alliance, Fresenius Medical Care North America for their generous support of this session. I would now like to welcome on the stage Marco Davis, President and CEO of CHCI, who will provide some welcoming remarks. Please welcome Marco Davis.
Thank you, Jose Pablo, as we say, JP, as I know you like to be called. Buenos dias a todos. Good morning, everyone. As JP said, welcome to the 2023 CHCI Health Summit. Thank you for joining us today as we convene members of Congress, Hill staff, corporate executives, industry experts, community advocates, and CHCI program participants and alumni for discussions around the health of Latino communities and the nation. And what better time to host this health summit than in April, which happens to be National Minority Health Month, a month meant to raise awareness about the health disparities that continue to affect people from different racial and ethnic groups in the United States. Now, throughout the day, starting with this plenary, you'll hear about the highs and the lows of healthcare. Experts will reflect on the successful policies and initiatives that are strengthening Latino health equity and leading to affordable, high-value, sustainable healthcare. But you'll also hear about how 15.8% of Latino deaths each year can be attributed to heart disease, and how 46% of Latinas of childbearing age live in states that restrict women's reproductive rights and the challenges this poses. Today, we'll have rich discussions and insightful conversation about how health, in all of its forms, has impacted the nation and the Latino community, and what we can do to ensure a healthier future for all of us. Now, we're kicking off this plenary, as was just mentioned, with this session, the summit with this plenary called The State of American Minority Health and the Future of Health Equity. But before we jump into that discussion, I want to extend my sincere thanks to all of our sponsors for the summit throughout the day, including our champion circle sponsors, Amgen and Fresenius Medical Care, for helping to make this issue summit a reality. And I want to thank each of you for being here with us today. I hope you enjoy all the discussions we have lined up and that you will join us soon at the end of the day, that you will join us for the closing reception when we finish all of our discussions. Remember that you can engage with us on social media using the hashtag CHCI Summit to extend the conversation beyond this room. Also remember that we'll be recording this and all of the sessions throughout the day, and we'll make those available online within a week or two after the summit. And now, throughout the day, you will be introduced to each of our sessions by one of our own incredible leaders, one of our public policy or one of our postgraduate fellows. You've just met Jose Pablo Rojas, CHCI PepsiCo Health Public Policy Fellow, and you're going to see many of his colleagues who are doing incredible work, who've been spending the last 7 months, where we have 2 now, doing incredible work on Capitol Hill, in the White House, with national nonprofits, and even with some of our corporate sponsors. They are truly leading the way, and they are demonstrating that the future is in good hands with this next generation of leaders. But now let me turn it back to JP to get us started with this morning's conversation.
Thank you, Marco Davis. I am now pleased to introduce and welcome to this podium Sylvia Cruz Vargas, Global Community Impact Regional Lead Americas at Johnson & Johnson. Welcome, Sylvia.
Good morning. My name is Sylvia Cruz Vargas, and I am Johnson & Johnson leader. Let me start again. Good morning, everyone. Good morning. How is everyone doing? Let's restart again. My name is Sylvia Cruz Vargas. I am Johnson & Johnson Global Community Impact Leader for the Americas. I work in our social impact team, and it is an honor to strengthen our relationship with the Congressional Hispanic Caucus Institute and support today's Health Summer Plenary Session on minority health and the future of health equity. Before we start, we Latinos always want to say thank you. And today, we'd like to say thank you to Marco Davis and CHCI, my fellow sponsors and speakers, this wonderful plenary, and all of you who are joining us today to support this critically important discussion. I am honored to be among such distinguished policymakers, business leaders, and community leaders, all of you who are coming together to celebrate Latino excellence and address our community's most pressing needs. As you think about what are those most pressing needs, for Latino people, one of our most basic and critical needs is access to quality healthcare. As you can imagine, unfortunately, for Hispanic Americans are less likely to have health insurance and to receive preventative medical care than other Americans. In fact, Hispanics had among the highest uninsured rate in the nation at 17.7% in 2021, according to a report of the US Census Bureau. Now let's talk a little bit about who we are as Johnson & Johnson. I just want to introduce the sponsor and the company. But as one of the most diversified and only healthcare product company dedicated to blending its strong pharmaceutical and medical technology capabilities, Johnson & Johnson is committed to impacting the health for humanity, reflecting on our commitment outlined in our credo. It quotes, "We are responsible to the communities in which we live and work and to the world community as well." As part of these efforts, we're working to eradicate racial health inequities and address the harsh that Latino, Black, Indigenous, and people of colors, also known as BIPOC, communities know all too well that the color of your skin is too often determines your access to care, quality of care, and health outcomes. Matter of fact, in 2020, Johnson & Johnson launched our Race to Health Equity, committing $100 million in the United States over a 5 period of time to invest and promote health equity solutions. What we're trying to do in reality is to change the health for humanity and the culture of healthcare in different ways. And I'd like to take just a few minutes of your time, I know we're between this wonderful panel and the rest of the day, just to tell you about how we're cultivating healthier communities and building enduring alliances. We do this by what we call the Johnson & Johnson people-first culture. Many of you will wonder what our people-first culture, what it is, and how are we going about it. But let me tell you, we're committed to a diverse and inclusive workforce. I am one of the proud examples of many Latinos working for Johnson & Johnson to increase ethnic, racial diversity across the organization, including at the managerial levels. One of the ways we are working towards achieving greater diversity is through our 12 enterprise ERGs, also known as Employee Resources Groups. I am a proud member of HOLA, the Hispanic and Latino ERG, and it stands for the Hispanic Organization for Leadership and Achievement. Through our HOLA ERG, Johnson & Johnson signed the Hispanic Promise, a first-of-its-kind pledge to hire, promote, retain, and celebrate Hispanic and Latinos in the workplace. And we are currently working in our upcoming HOLA Summit that will happen next week, and we're so excited to count on the support from our CEO Joaquin Duato as we come together to celebrate Latino culture at Johnson & Johnson. In addition, we're working outside of our company to support healthier communities. We know that to cultivate, innovate, and find inclusive solutions that result in healthier outcomes for Latin people, we must include those communities in which we live and work in the development of our treatments. To that end, we are working to increase diversity in clinical trials and are examining how trials are designed, the criteria for participants, and how clinical trial site staff engages with Hispanic, Latinos, and other communities. We're also educating Hispanic, Black, and Asian American communities across the United States about the clinical trials and the importance of diverse participation. I've mentioned a couple of times the topic of enduring alliances and how we go about creating partnerships. We're keenly aware that no single organization can tackle this issue alone. We value the opportunity to create enduring alliances, and we're here to partner and learn from leading organizations, each one of my fellow panelists as well, and CHCI, government officials, and others who have been doing this work for decades. At Johnson & Johnson, we seek to uplift the work of trusted community partners around the world, and I wouldn't be here if I wouldn't mention some of the efforts that we do in Latin America. For example, in New Brunswick, where we have our big campus, we're working with Spanish-speaking immigrant communities in our own backyard. We're incredible promotoras de salud, those are community health workers, have an initiative with the Robert Wood Johnson Hospital to provide vital holistic care and serve as a trusted bridge between their communities and the formal health system. In addition to that, you'd like to know that in Brazil, we're working with the Institute for Healthcare Improvement and Hospital Sirio-Libanese to create a program called Reconectar in 2021 to help boost well-being, satisfaction, and engagement in the healthcare worker day-to-day working environment. Lastly, how not to speak about Mexico, and we have to talk about Mexico here. And we collaborate with health services, academic, and non-for-profit institutions to improve dignified treatment to indigenous and Afro-descendant communities in the most impoverished regions. Now, I am just one talking point away and leaving you with this wonderful panel, but I would like to close by telling you that Johnson & Johnson believes that when all the communities we serve have a seat at the table, we work together as change agents in healthcare and beyond to lead healthier outcomes. Finally, as the opening CHCI fellow said, we want to say thank you for your time. We look forward to expanding the work we do together for the betterment of our community, and let's reveal the culture of healthcare together so that every one of us and our future generations can live longer and healthier lives, lives in which we can celebrate our rich history, build on the legacies of our leaders, and help the next generation pursue its own version of the American dream. Thank you very much.
Thank you, Sylvia, for all that you do. It is now my pleasure to introduce today's moderator. Elizabeth Aguilera is an independent, award-winning multimedia journalist focused on the intersection of policy and people around health, environmental health, and social services. She is a freelance journalist and editor-at-large for Zócalo Public Square. Aguilera has been a journalist for over 2 decades across platforms from print to public radio, digital to podcasts. Please welcome Elizabeth.
Thank you, and welcome to this great day that's going to be so interesting, I think, and in-depth, and reveal, I think, to us so many things that we are working on, can help us in our work, and to move forward into the future. So as Jose Pablo said, my name is Elizabeth Aguilera. I am a journalist. I've been covering health issues for quite some time. I've covered immigration and Latino communities, urban affairs, And I am really happy to be here with you today. Sorry, I came from Los Angeles, so I'm a little off on my time. But thank you again to Jose Pablo Rojas and Marco Davis for setting the stage today for the content of our conversation. I'm really excited about this. And of course, thank you to CHCI for hosting this health summit and for focusing on the strengthening the Latino community and Latino immigrant health equity specifically, and what needs to be done to achieve affordable, high-value, sustainable healthcare. But also, I think talking about access is going to be our most important topic, at least this morning, with the panel we have today. I did want to also mention that if you're sharing on social media, you want to use the hashtag CHCI Summit so that people can follow what's happening today, both in this plenary and throughout the rest of the day. And I want to give just a little intro to our plenary, and then we'll jump in with our wonderful guests. So in this conversation, we're looking specifically into some unique health issues. I know this is the state of American minority health and the future of health equity, but you can't talk about that without looking at very specific challenges for the community, and this panel is going to bring some great insight on those in terms of the lack of access, because it impacts outcomes, and I think that's what we're here to talk about today. And these organizations are looking at those issues and also working on closing those gaps. So let's just jump right in. I'm delighted to be joined by these four experts, and I want to start by giving you each an opportunity to introduce yourselves. You can take up to 4 minutes, talk about who you are and what you do, and why don't we welcome Dr. Jeff Aletta. He's the Senior Vice President and Chief Scientific Director for Be the Match.
Thank you, everyone. Thank you, Elizabeth. I will not take 4 minutes. So my name is Jeff Aletta. I'm a pediatric bone marrow transplant infectious disease doctor. I also now work at the National Marrow Donor Program, and I want to thank each one of you in the audience for supporting our organization, because through federal dollars, you support the National Marrow Donor Program. So at the National Marrow Donor Program, we are the nation's registry for volunteer donors who want to give their cells to another human being. Wow, what an altruistic thing that is. So what we know about that is that the ability to match another human being to a patient is based upon the ethnicity of the patient. So the more ethnically diverse you are as a patient, the less likely, unfortunately, you're going to find a match in our registry, because the registry is comprised mostly of people like me rather than people like you. It needs to be more of people like you in our registry in order to then serve as a stem cell donor for a patient in need. We know that the Latino population has an increased risk of certain diseases, such as something called Philadelphia acute lymphoblastic leukemia, or cancer of the bone marrow. That is a transplantable disease indication. So therefore, we know that the chance of a patient who has Latino background with ALL getting a donor is about 50% versus 76%, such as myself if I had the same disease. So our organization really needs your participation in order to join the registry to serve as a stem cell donor for another patient in need. And then briefly, what we do in addition to that is we define barriers to stem cell transplant for patients. We know that there are barriers at the patient level, at the provider level, and at the transplant center level. Patient level, I just told you about that in terms of ethnic diversity, but also socioeconomic. The people on the heritage in this room is overrepresented in terms of lack of health insurance as well as poverty, despite being underrepresented in the society that we live in right now. So that's a major barrier. We know at the provider level, providers don't have that education enough to know what are some of the transplantable disease indications, particularly for ethnically diverse people. And then lastly, our organization is working to define research that overcomes those barriers to provide a donor for all. So thank you very much for your participation and allowing me to be here.
So next, let's welcome Dr. Veronica Sandoval. She's Principal Patient Inclusion and Health Equity for Genentech.
Thank you, Elizabeth. And I'm just thinking, how am I going to follow Jeff? I should have been later. But, thank you, everyone, and thank you, CACI, for inviting Genentech to be part of this panel. As Elizabeth mentioned, I am a principal in the Patient Inclusion and Health Equity team at the Chief Diversity Office at Genentech. And one of the things that we always say at Genentech, and it's a similar theme that you'll be hearing today, is that we are committed to having diversity and inclusion and equity at the center of what we do. I think I'm good enough. And one of the things that we want to do at Genentech is really target, understand how can we work and continue working with our community. You just heard Jeff talk about the underrepresentation in data. That is a huge problem. Because even when you talk about Genentech, where we innovate medications and are thinking about the next targets for those innovative medications, and you look at the data that we have, 90% of the genomic data that we have to date and that scientists rely on is from European ancestry. The All of Us program at NIH is trying to change that. And it's trying to collect data and have a biorepository that is reflective not only of Latinos, but of those who are underserved. And that's what we need to do. It is a collaboration of industry, of government, of nonprofits and patient advocacy groups, and even health systems in this country to start changing the data that is being collected. Even from a clinical trial perspective, one of the things that we're trying to do at Genentech is how do we collect data that is consistent throughout the different programs that we carry? Genentech has a very diverse portfolio from oncology, neuroscience, rare diseases, ophthalmology. And even though that we are one company, there are silos. And we're trying to break those silos in order for the same data to be collected across all of our portfolio, because that is key and that's going to be important as we're trying to understand what is it that makes us unique and how can we ensure that all of our drugs that we innovate are going to be effective for all of the people that we are trying to serve in this country. Finally, when we are thinking about ways of innovating, we do not forget about our important partners. At Genentech, back in 2021, we launched the Advancing Inclusive Research Site Alliance. And we started with 4 founding sites in oncology. And the reason we focused on these 4 sites, City of Hope, Mace Cancer Center in San Antonio, West Cancer Center in Memphis, Tennessee, and the University of Alabama, was because these centers in oncology, they know how to work and trust, and they have the trust of the community, not only of their Latino and their Black patients, but they know how to talk to those underserved communities. They know how to engage, retain, and recruit for clinical trials. So the thinking was, well, if these sites are so good, how can we bottle up the secret sauce and share those best practices across our diverse portfolio? And I am proud to say that this year we have expanded that Airside Alliance to include 2 more sites in oncology, Montefiore in New York and the University of Illinois in Chicago. But not only are we thinking about oncology, we're also thinking, how can we take this model that has been successful in oncology and expand it to other areas? And one of those areas is ophthalmology. You've heard about statistics from Jeff, and it's not surprising that when we think about our Latino community, and for that fact, our Black community as well, and Native American communities, that diabetes and obesity are a huge problem. And these are chronic conditions. And what comes along when you are not having access to healthcare and you cannot manage your diabetes? You start losing vision. Vision, unfortunately, should not be lost because you could detect it early with preventive care and with an annual eye exam. And that is why we're expanding into ophthalmology, because we want to prevent diabetic loss of the vision loss due to diabetes. So there is exciting work that we're doing at Genentech to address health inequities. But again, partnerships across the industry, across the different partners is very critical and important. Thank you.
And then next, let's welcome Ramita Tandon. She is the Chief Clinical Trials Officer for Walgreens Boots Alliance.
Thank you. Good morning, everyone. Thank you to CHCI and all of you for being here today and being able to have such a forum to be able to talk about a number of healthcare issues. For those who don't know Walgreens, we are a retail pharmacy organization. We have 9,000 stores and pharmacies across the nation. 78% of the US population is within 5 miles of a Walgreens. And we've got the brand, the trust. We've been in place for about over 120 years within the fabric of our communities. And so in 2021, we made our formal announcement to move into healthcare. And we made some significant investments to build out our healthcare continuum, both in primary care, specialty health, as well as home health. And the catalyst behind us to really put more emphasis and focus around healthcare was certainly during the COVID-19 pandemic. As you know, when things were all shut down across this nation, the retail pharmacies were the ones that were opened. And it was a very challenging, high complex time for people to navigate. There was tremendous amount of mistrust, fear, lack of information around the vaccinations. And I tell folks it wasn't a one-size-fits-all strategy that there was advertisements or what have you to be able to say people need to get shots in the arms. Rather, the Walgreens, as part of the retail pharmacy ecosystem, had to unlock the relationships that the pharmacists and the pharmacy care teams had with their communities. And when people were coming in to ask the questions, there was times of education, enabling, and ultimately igniting what we call empowerment of people, so people felt comfortable that they had enough information to get shots in the arms. So we thought, boy, with all of this work that we were able to do, we administered over 70 million vaccinations across the US. And that was just part of the broader retail ecosystem, retail pharmacy ecosystem that I think did over 200 million vaccinations across the US for the nation. And so from our perspective was, what can we do more to leverage our relationships with the communities and start to build more connectivity within the local communities and start to tackle areas of health equity, diversity, and access. And so with our investments in healthcare, we are unlocking our locations to become healthcare destinations where patients and consumers can go in to be able to get low acuity types of services, so screening, diagnostic, phlebotomy services. And part of that is to say, how do we make healthcare more accessible? How do we start to not just talk about access, convenience, and we got to talk about health equity? We at Walgreens are unlocking the full assets, our capabilities, and all the investments that we're making to make sure that we can make healthcare more accessible to the communities that we serve across this nation. And so my role as the Chief Clinical Trials Officer is to take it one step further as we, Sylvia and Veronica have talked about clinical trials. Less than 5% of this nation participates in clinical trials. And those that participate, 75% are Caucasian, which means the drugs that are out there today, 1 out of 4 drugs elicit variation responses across various ethnic groups, including the Hispanic community. And so as we are using our locations, our pharmacies to become healthcare destinations, we're converting them as well as clinical trial centers. And so, I've been very open and transparent as we've launched this clinical trials program last year in the industry. We can't do this alone. We certainly can bring to the ecosystem our assets, the 150 million folks, that we serve across this nation. How do we bring trials closer to patients so we make it accessible and convenient? And so for us, we are offering a flexible set of options, one being to be able to open up our pharmacies, using our pharmacists and our care teams to be able to first educate people on what a clinical trial is. If less than 5% of this nation participates in clinical trials, that means the lion's share of this nation have never participated or even know what a clinical trial is, or have been invited to participate. So the first step is to use our pharmacies as a welcome entry point for patients to come in and learn about what a clinical trial is. Then to feel comfortable that they know and to feel empowered to make a decision that participating in a clinical trial will not only benefit their health outcomes, but also in the communities that they're part of. The second piece is we hear a lot about technology. There's a lot of technology that's out there to really disrupt how clinical trials is conducted. So we believe that there's an opportunity to use sort of a hybrid solution, so where we are able to bring technology to enable better workflows or allow for more convenience for patients to go from their apps or from their homes, we're able to do that. So we offer that hybrid solution. And then for those that are a bit more savvy or have the opportunity to do so, we can bring clinical trials to patients' homes. Through our investments that we've made with home health, we have the opportunity to make it more convenient, particularly if patients are unable to get to our locations or to academic centers. And so I want to be clear, we're not here to disrupt the current provider-patient relationship. In fact, at Walgreens, we believe we need to be a supporting mechanism to a number of stakeholders that all participate in clinical trials. We recognize we cannot do this alone. You hear the theme of partnerships. It's going to take an ecosystem of stakeholders all working together to really tackle the areas of health equity, diversity, and access. So look forward to our discussions today.
And finally, please welcome Dr. Cristina Treviso. She is Manager of Health Equity for Fresenius Medical Care in North America.
Hi, good morning, everyone. It's such a pleasure to be here. My name is Cristina Treviso Nemeri. I'm the Health Equity Manager for Fresenius Medical Care. Maybe you're not familiar with our organization. We are the largest dialysis provider. What makes us the largest is that we are not only a provider, we are also a manufacturing company, and we manufacture all of our own products as well as providing dialysis services. But we are also global, which sets us apart from other dialysis providers. We have a large footprint in Latin America, South America, Mexico, Central America. We're all over the world. Our biggest focus for health equity changed during COVID as well. Obviously, our patients had no choice but to leave their home and come to dialysis because it is a life-sustaining treatment. And what we noted is that our patients of minority communities were having a difficult time and were really, really impacted by COVID-19. It was very difficult for us that we had to provide additional assistance, transportation, because we had isolation units. So how do we get this patient who lives now 10 miles or 20 miles or 30 miles from their new unit, because it is an isolation unit? So during that time, right after COVID, we created our diversity, equity, and inclusion team. And my role as the health equity manager is part of that team. I am a nurse by trade, 20 years plus. I won't say exactly, because then I'll age myself. But I'm very excited and passionate about health equity. As you all know, Black, Native Americans, and Hispanic communities are more apt to have a kidney disease, but they're also more apt to progress to end-stage renal disease and need dialysis. They get there, not only do they get the disease more often, but they progress through the disease process a lot faster. And that is just a result of the high incidence of diabetes and high blood pressure in these communities. Our Hispanic patients are 1.3 times more likely to suffer from kidney disease. Again, kidney disease is relevant to all of us. 1 in 3 people have kidney disease, but our minority populations are more apt to have it. So of course, that means for Fresenius is that half of our population comes from underrepresented communities. So we have really focused on how do we make an impact on these patients. What we've also noted is that they're more apt to be there, but they're less likely to use our treatment options that offer better outcomes, like transplant and home dialysis. Okay? So how do we get our Latino patients, our Black patients to home, to transplant, to better outcomes, to lower mortality rates, to a better quality of life? So what we've started doing is really evaluating social determinants of health. We're starting to assess our patients. We realize that it's a missed opportunity when our patients are coming to our facilities 3 times a week to receive treatment, and they just come in, we dialyze them, and they go home. Okay, well, what is really going on with this patient? Why can't we get them through the transplant process? Because unless you're familiar with that, it's a very complex process that would be difficult for anybody here in the room, let alone our patients, when you start really looking at health literacy, language barriers. That's very difficult for our patients. So we're starting to look at those, again, transportation, access, food insecurity, housing. How do we help our patients? How do we partner them with community organizations? Obviously, Fresenius is not going to be able to make an impact in housing, but how do we connect our patients to those organizations that are going to be able to lead our patients in the right direction? We are working on a couple of pilots in Chicago specifically to assess for those social determinants of health and really make those connections to community-based organizations. We're also looking at upstream. We realize our responsibility in preventing kidney disease and disseminating education about preventing it, about what it is, how common it is in our populations. We have a commitment to representation. We understand that when we're sitting, myself, a Latina, sitting in a role for health equity, and I understand the fact that we don't go to the doctor unless we're sick. We don't go to the dentist until that tooth is hurting. It's like, okay, well, I should go get that pulled out. But that's not helping to getting checked for kidney disease, how your blood pressure is doing, how your blood sugars are doing, and are you already in progression to kidney disease? That is one of the biggest problems that we find. By the time you have symptoms with kidney disease, you're already in stage 4. Very close to stage 5. Stage 5 is when we start dialysis. There are no symptoms in stage 1, stage 2, stage 3. Okay, so unless your doctor's checking, no one's gonna know. So how do we teach our patients to ask, hey, I'm diabetic, I have high blood pressure, I have high risk, how are my kidneys doing? It's a simple question. So how do we advocate for ourselves? So that is one of the things that we're also focusing, again, upstream education, getting our patients to primary care, and learning about kidney disease. We have this one great partnership with the Boys and Girls Club of America where we're doing, it's called Kidney Kids. So we're going in and educating on nutrition and healthy eating with the littles, because we know that's where it starts, right? If my parents were eating a certain way, but also being culturally sensitive. Like, what are those healthy foods that you're not gonna tell me, you can't eat this, you can't eat this? Well, I'm not gonna give up all that food because that's what I've been growing up eating my entire life. So those are the things that we're really working on. Again, my role is not just advocacy, it's education for our employees as well. Cultural competencies is very important. Again, if our patients are, half of them are from minority populations, how are we providing care that is culturally competent, is being sensitive and knowledgeable to what their needs are? Thank you.
So before I jump into questions, I just want to remind everyone again to, if you're going to tweet your comments or follow the discussion both in this room and online through social media, to remember to use the hashtag CHCI Summit so people who are following can capture all the impressions and perspectives that you're putting out there. So the first question I have, and some of you touched on this already, was your initiatives that you represent and what they're working on. So I want to go to health access, and you did talk about that a little bit. But for communities of color, what is access like? I mean, you talk about how there's very few people in the registry. There's very few people having clinical trials who are from communities of color. Back up a little bit and tell us why that is, and what is the work that actually has to be done to bring people in? Because you can bring those clinical trials to community, your Walgreens, or you can, we can have these discussions, but how do you actually reach people where they are to get them to come to the Walgreens for the clinical trials? I think Walgreens as a place to go for care is going to be, people know you, as you talked about, Ramita, people know the brand, people go there already. So I don't know that that's a challenge, but in terms of clinical trials or to be on a registry, to understand what that is, how do you actually reach people to do that?
I could start.
You want to start?
Yeah. That's a great question. So, I think historically, or even today, and I think my colleagues here on the panel and others can attest to this, that for so long, clinical trials or research has tapped into the same set of American medical centers, the same patient populations in areas that might be more affluent areas, areas that have payer coverage, et cetera. And so we have neglected to go into communities that have never had access to research, even understand trials. And so from our perspective, it is, how do we just do the hard work? And it's one thing about just sharing information about clinical trials, because to some extent, if you don't know about it, you're going to say, what is it? And the dialogue between the provider and the patient, it's not happening happening organically or naturally, saying, you've got an illness, I'm going to put you in a clinical trial. From our perspective, we're unlocking our locations to become those initial welcome entry points for patients to come in, whether it's using one of our digital kiosks, and you're going to start to see more as we look to expand the use of our store formats. How do we use our physical footprint as a mechanism for patients to come in and just learn about clinical trials? We have a number of trials ongoing, for example, where if a patient picks up their prescription and a patient's eligible for a particular clinical trial, it gets flagged in our pharmacy systems that allows the pharmacist to say, hey, listen, you've had uncontrolled cholesterol, you've been on a couple cholesterol meds, there's a particular trial that actually might be well suited for you. And that's just an example of, well, the dialogue will pick up, and then the patient will say, well, what is a clinical trial? And within our locations, we have a significant number of our locations that have private health rooms that allows for then a pharmacist and a patient to go out separately and have that dialogue about what a clinical trial is, how it's going to benefit, the risks and the benefits, so that they feel empowered, that they got the information, and to be able to sign up. So for us right now, we're doing that hard work of just educating. I call it the triple E framework, right? It's just educating, enabling, and empowering folks to feel comfortable and to be able to sign up for a trial. And then I think it's just a matter of then working within our local communities, because we recognize, especially during the COVID-19 pandemic, we couldn't do it alone. So as you heard from each members of the panel here, it will require some partnerships with faith-based organizations or others that understand the Hispanic community, the Black community, and start to break away some of the preconceived notions that may already be within the populations. There's a lot of mistrust. There's a lot of fear that exists about just taking a new medication, and or perhaps healthcare alone, or the big pharma community.
Well, I was going to ask you about that, and I know you're probably going into that, was to how do you address the skepticism, right? The historical experiences that people have had with clinical trials or medications, or not knowing they were participating in something. Even that has happened. So you're going down that road, Ramita. If you want to jump in, Veronica, or others, but how do you get to that? Because you have to address that skepticism, that fear.
It's a big, and look, it's the real world that we live in today. When we're in the communities, particularly communities that are unsupported or have dealt with some of those historical atrocities in clinical trials, we are bringing in patients that look like them and have gone through trials and provide their feedback of their experience and what it did for their health. We also need to help people understand that in areas like kidney disease, diabetes, some of these big chronic diseases that are impacting our nation, that we need them to participate to start to move the needle around, how does the impact of that drug impact, the Hispanic, the Black populations. So when we get this information, you heard Veronica talk about data, that data that we're getting from clinical trials is actually representative of the US population. It's not an easy conversation to have. And that's the real world that we're sitting in today, is to be able to start to unlock those types of preconceived notions. But it's the dialogue, and particularly the trusted relationships that pharmacists have with their patients. It's helping to sort of help people feel at ease and to be able to feel comfortable to sign up. It's not going to happen overnight, and it's going to take a number of partners within local communities to help unlock those conversations.
Well, Jeff, I would imagine Be the Match has the same challenge, because when you talk about being on a registry or taking some, bio data, how do people respond, and how do you also get past that with communities that have, pretty, I think, you have to understand the historical concerns.
Yeah, it's a great question, Elizabeth. So I want to take a step back. Certainly our organization wants diversity in clinical trials, wants to provide access to high tech, and transplant is a very complex procedure in terms of whether it's solid organ or stem cell. And obviously we want data in terms of biorepository. But I really want to kind of step back, because we're all here in this room, and so we're like, so why is there a problem? Right? I mean, we're all here, all the companies have all this stuff, so why is there a problem? I think it has to do with two things. I think there is the patient, and then there's the healthcare system / society. And quite frankly, the patient, again, I told you I'm a pediatric cancer doctor. Let's say you have a child, and I just diagnosed your child with acute lymphoblastic leukemia, and now I'm going to talk to you about bone marrow transplant. Right? You are emotionally overwhelmed. You have no idea what bone marrow transplant's about, and now you have to get this 30-page consent form that's written in English versus your own native language, right? And here I am trying to explain to you all the complications of bone marrow transplant that are associated with it, and then, oh yeah, we're gonna, you have about a 50% chance of getting someone who can help out your child, right? I mean, that's our first fundamental problem, is awareness of what some of these very entrenched problems are, and quite frankly, at the society level. So again, why are we all here? Why are we all tooting the same horn? It's because America is such a great place. But until America fundamentally invests in its own people, that will always be a major impediment. And it goes back to, people are living in poverty, right? People are living in poverty. It's remember, for those who know about Maslow's pyramid of needs, right? You start off at your physiologic need. If you have to worry about safety, food, and shelter, you're never going to understand the top, right? You're never going to understand what's available to me in terms of how to, make me the most successful patient in terms of education and clinical trials and all. So those are the two things. I say that because, it's a personal thing because I've seen it happen. I've seen that happen. And, it gets back to what are we willing to really do in this country? What steps are really due? We've got plenty of heroes. We need leaders, right? We need leaders who understand the fundamental problem, who are going to work together to come up with solutions.
And I just want to add, because I love that energy, Jeff, because I'm like, yes to everything you're saying. But, one of the things that is fundamental, and I think you touched on it, is as we have all of these programs across the industry, across government, across healthcare systems, you touched on it, and you hit the nail, which is there is systemic healthcare racism in this country. And even as simple when you start looking at, going back to the 30s, right, when we're in the Great Depression, and all the redlining that happened in this country. That redlining is still here, still very real. We're talking about access to healthcare systems. Even when you look at those redlining zip codes, counties, you can still see that they're primarily Latino communities, they're primarily African American communities. And when you look at the access to healthcare, sometimes they don't even have access to an emergency room. They don't have access to a pharmacy. So how do you expect our communities to do better than they can when they do not even have access to that? And even another impediment for the Latino community that we haven't touched upon is documentation. Right? When you even roll that fear of, am I going to be deported? What is going to happen? And I think that is the reason that we are all in this room, is all of us know the problems. Let's start talking about solutions. Let's start talking about what can we do, even in the privileged positions that all of us are sitting in. Even when we talk about the patient, one thing that we say at Genentech, and you probably hear even our Chief Diversity Officer, Krita Highsmith, stresses it, it's a big stressor of hers, is that we have to stop blaming the patient. When the patients are thinking about the social determinants of health, they're thinking about, am I going to have food on my table? I'm going to have a place, to be in. Healthcare is the last thing they're thinking about. So what we're thinking is, what can we do and work with the communities and those trusted community partners that we have to start thinking about access? What do we think of when we think about access is screening. Everything starts with screening. And we heard about this even from Ramita, and all of us here on the panel. When you do not know you have the high blood pressure, You even spoke about it. When you don't know that you're going to have that kidney, at stage 1, that it could be caught at an early screening, what can we do with our own industries? And one thing that we're doing at Genentech is partnering with community partners that are embedded and trusted in the community. One of those examples is Dia de la Mujer Latina, which is, maybe some of you have heard of Dia de la Mujer Latina, which is based in Houston. And they're a very unique organization because they just do not put programs together. They call them fiesta fairs. Because again, you have to know your community. In order to bring those Latinos out, you have to have a fiesta. You cannot scare them that you're going to come and have all these screenings done and then you're going to end up with a disease. But not only are you providing, as Dia de la Mujer providing the screening, they are a group of promotoras that navigate those patients from screening to care, to point of care. Because that's an important piece, that you need not only to educate, but not only provide that public health literacy of the disease itself, but also how to navigate the healthcare system. Because I don't know about you, but when I go to the doctor and then someone tells me you have to go and find an oncologist, I'm savvy enough that I'm like, okay, let me go to my United Healthcare, let me figure out how to use it. But if you are from a culture that you do not understand how healthcare works in the US, that's a huge impediment. When you don't understand that you could use healthcare if you're, have the privilege of having healthcare, that it is supposed to be used as a tool of prevention, that you need to go and see the doctor in order to prevent disease. So that is where education needs to start, and that's where these organizations like Dia de la Mujer Latina really shine and help us rethink that. And even from a clinical trials perspective, one of the things that we, and Ramita touched on this, is that you have to rethink where those clinical trials are placed when you're coming to sites. Ramita did share that less than 5% of the US population participate in a clinical trial. But when you look at Latinos, they're 18% of the US population, but less than 1% participate in clinical trials. Education is important, but again, you have to go back to the root cause. And that root cause is that there is racism, there is unconscious bias when you have the principal investigator across the room that is making assumptions as to why the patient would not be a compliant patient to go through a clinical trial. That is why partners like the Mace Cancer Center in San Antonio are very important to have, because they're helping us at Genentech think about how do we dismantle that unconscious bias. And they're helping us co-create materials in Spanish to educate the patients, empower the patients to know what do I do as a patient, and also healthcare providers. Do you do this? Start raising flags and having those real conversations, because that's where change is going to start happening.
Well, I want to touch on one more thing before we get to Q&A from the audience, because I'm sure you all have questions for our panel. I want to specifically ask you, Cristina, about this issue of healthcare and insurance, because I know you mentioned that communities of color, your patients that are Latino, African American, that they go through the process to transplant much less than other groups. Talk about why that is, because we know that there are issues, the socioeconomic issues also of Medicare, Medicaid. So talk about that, because I think that's really important. And then I know, Jeff, you can probably address that as well in terms of match.
Absolutely. If you all are not aware, with our patients, once you become end-stage renal disease, so you've reached a GFR of less than 10% and you're going to start dialysis, you automatically qualify for Medicare, regardless of age, regardless of anything, whether you're 5 years old, whether you're 100 years old. Medicare will automatically pay for 80% of your dialysis costs if you've acquired the coins, right? And then you have that 20% that will be covered either by primary health insurance, Medicaid, or out of pocket. Again, that becomes an issue. It's fabulous, right? A lot of other countries don't provide that. You have to pay out. In Mexico, you have to pay out of pocket for each dialysis treatment. And you're thinking 3 times a week for the rest of your life. When it becomes an issue with transplant is that once you become transplanted, you're no longer considered end-stage renal disease. So you're gonna lose that coverage. And if you've been a dialysis patient for 15 years, a lot of our patients will file for disability because it's difficult for them to work when they're going to dialysis 3 times a week for 4 hours and they feel exhausted. So they will stop working, lose their healthcare coverage, depend on Medicare for their coverage, and then they lose it when they get transplanted. So now how do you cover the cost of your medication? How do you cover the cost of follow-up care for transplant? So what is the issue a lot of times is the patients will be rejected from the transplant list because if they don't have some form of insurance or coverage. So how do we address that? A lot of our patients are also undocumented or don't have, so they won't qualify for Medicare. Again, big issue for our patients. We don't deny any patient, and we provide indigent care, and we will just take that hit. But it's difficult to move them through that process of how do we get you transplanted so you could go back and live your life? How do we get you on home dialysis? I know we had a discussion prior. If you are on emergency Medicaid or emergency care, you will qualify for the permanent access for in-center dialysis, but it won't cover the placement of peritoneal catheter, which would allow you to go home. So again, difficult barriers for our patients to really receive the optimal care. We don't want a 20-year-old sitting in center 3 times a week. We want him transplanted. We want him out there working. We want him at home doing dialysis overnight so he can wake up in the morning and go work and be a productive member of society. But if he doesn't have insurance, he's stuck doing dialysis 3 times a week for the rest of his life. So those are some of the barriers that we have. That we know we had some recent issues where there are certain carriers who will not cover dialysis as part of their care. That's difficult because if they don't have Medicare, if they don't qualify, or they're trying to get transplanted and get a service, it's not covering the care. So it's difficult for our patients.
Jeff, is that a challenge for Be the Match as well?
It is. So again, a very similar story, and that is, unfortunately, the American healthcare system is Swiss cheese, right? People fall through the holes all the time. And that's a great example that Christina gave in terms of the differences in Medicare coverage. And that's something that we're very interested in. And along with some partners in the ecosystem, we're actually querying Medicare coverage for transplants that are performed in each of the 50 states. And guess what? Every state is different in terms of what the indications are, what the benefits are, and also with regards to the ability to receive the transplant in terms of an indication. The other thing is the same thing for cell therapy. So you've probably heard about these CAR T cells. So it's an amazing field, very complex. We use cells in order to restore the immune system, but we now use cells in order to fight cancer. So we can take out cells and educate them to infuse back into the patient and attack cancer. That's essentially what a CAR T cell is. And that Medicare coverage is different across states. So at Be the Match, we have a whole patient services, my team, that really helps out in terms of educating patients, both in terms of the whole transplant journey, which is very complex, as I mentioned, providing patient financial assistance through donations, for example, in terms of society that goes to our foundation and donates so that we can provide financial assistance to patients. And we also provide clinical trial education for the Jason Carter Clinical Trial Search and Support. So where you as a caregiver or a patient can look to see what there might be an available clinical trial. But all of this requires some level of sophistication, and we all just talked about that. And I go back to Maslow's pyramid of needs. And so, again, I think we need to bring things to the community. We need to gain the trust from the community in order to make the best difference in terms of patient outcomes.
Well, we want to give you an opportunity to ask questions. I know there are some microphones, or yeah, there's a question up here. And yeah, just raise your hand and we'll come around.
Okay, there we go. Hi, everyone. My name is Omar Martinez Gonzalez, AIDS Foundation Chicago. And before I start, I want to thank Dr. Treviso Nimeri for mentioning the undocumented community. It's, they're left out of safety net opportunities, and that's not something that's usually talked about. So thank you for that. My question is around clinical trials and engagement of the Latino community. I'm a scientist, so I understand first and foremost the importance of engagement in clinical trials for our community, for representation matters. And actually, with that in mind, I ended up participating in the COVID-19 trials for Johnson when that was happening during the pandemic. As someone who has tremendous privilege, I still face a lot of barriers in continuing to participate. And when it was all said and done, when they had finished the trial, they got up and left, and it was as if I had never participated in that trial. And so we talk about medical mistrust, and so our communities, what they're feeling is that these private companies that are coming into our communities to collect our data, to innovate, which really helps their bottom line. They may do a lot of work to educate our communities about why it's important to participate. They may incentivize during the process, but as soon as they're done, they up and leave our communities to hang and dry. So my question is, what responsibility do these companies have in sharing the data that they're collecting with our communities to empower them and or to create systems of continued support to help address the barriers or issues that they're finding in their studies?
Veronica, you want to try that?
Absolutely. I was hoping. I was like, please call on me, Elizabeth. No, it's a very loaded question, right? And I would say, if we start unpacking, that is what you're describing as that helicopter effect, right? Pharmaceutical companies come in, you do your clinical trial, and then you leave and you forget about the patients. And that, that obviously has to change. Because even when we are thinking, and I think even when Ramita was speaking about how do we have to reimagine this community engagement, that comes, why do Latinos, for example, why do Latinos come and participate in a clinical trial? It's because the doctor that asked them, they have that trust. They're able to explain. We in the industry need to do a better job in sharing the data back to the participants. And that is something that at Genentech we're trying and we are committed in doing. We're reimagining, and I'm using the word reimagine because we really have to reimagine how we are approaching our communities. And one of those things is data sharing. We have to share the data back, but and to your point, right, there's the literacy level across is a big spectrum. One of the things that we have at Genentech is that we actually put together back in 2018 our External Council of Advancing Inclusive Research. And these are 14 members of the community. These are thought leaders nationally recognized from oncologists, ophthalmologists, neuroscientists, and patient advocate groups, where these are the discussions that we're having. How can we, to what level of information can we share, and how do we share that information? And of course, it has to go again. Who was that vehicle that brought those patients to that community? Was the community physician, the healthcare provider, the institution that is part of that Latino fabric, because they're the ones that are better seated to share that information back, to say, this is how your data was used, these were the outcomes, and even if they're preliminary, because you have to understand when there's a clinical trial and you close the clinical trial, it takes time to analyze, and sometimes it takes years for that data to be published. So there has to be this continuum of communication, even of those trusted partners. The other piece that is always very important and that we also are looking at Genentech is how are we, when we are putting our clinical trial development programs together, how do we ensure that our clinical operations teams are thinking about all of these issues at the beginning, not as a hindsight? And for health equity to work across all of industries, health equity has to be embedded in the business. It cannot be an afterthought. Because if it's an afterthought, we're going to lose this battle and we're going to be back in 20 years and still have the same conversation.
Ramita, I know you want to talk about this and how you're thinking about this as you're creating this system. Just briefly, because I know there's more questions, but yes,
It's a great question. I mean, obviously for the 130 million lives that come to our pharmacies and stores, and as we started to get into the communities to listen, sort of the big issues, that was a resounding theme that we heard back is that, if they've participated in the past, they get a letter that says, thank you for your time and commitment, and then they don't hear back. And so at Walgreens, what we've done, and for those who know me know is, we talk less and do more kind of thing. We've created as part of our healthcare journey, clinical care programs. So when a patient finishes their obligations with a clinical trial, we roll them over into a Walgreens Health clinical care program. And the idea behind that is we want to close care gaps that, traditionally have existed in many of our communities that are today. And so our idea is to be able to, again, leverage our physical infrastructure as a mechanism to have patients come in for their screening diagnostics, particularly in diabetes. If they've got A1C that has never been controlled, we allow those patients after a diabetes trial to come in and make sure we're monitoring that. And then we have the ability to then coordinate with their providers and say, look, this patient needs to be seen because the health outcomes is not getting any better. So at least the part that we're doing from a Walgreens perspective is when a patient finishes a clinical trial, we roll them over into a clinical care program so that we can continue the support of that patient and making sure that we're improving their overall health outcomes. But that's a great question. And it's been a theme across many of the communities that we've surveyed.
Yeah, that's really important. I think it's the distinction between the transactional relationship versus a relationship, which I think many communities want to have relationships, but I found even as a journalist in interviewing people and telling their stories is people also want to have a relationship. And that is how people share themselves with you, either their story or their data or their health situations. And so I think that that's also a shift often for companies and organizations that focus on these issues. Is there another question in the room?
Buenos dias, Ricardo Sanchez. I work with Bristol Myers Squibb. Thank you all for being here. Excellent conversation. As we keep discussing the importance of diversity in clinical trials, something that we are also looking into is not just having the clinical trial sites closer to where the patients are or the communities in need are, but also having those trusted messengers and the importance of that, because if I'm not talking to somebody, or if my family's not talking to somebody that looks like them, speaks like them, understands them, there's not going to be that trust. One way is what was being discussed, la promotoras de salud, which is a very, very, very important tool. We are looking into not just having the diversity in the workforce, right? As important as principal investigators are, but also we're looking into taking it before that point. And this is more in the education space. So we're partnering with a lot of different organizations to provide grants and scholarships for the students, and we're partnering with HBCUs and other MSIs so that the future leaders and the future scientists and investigators have that pipeline. My question to you is, there's different industries being represented here. What are some of the things you all are doing in this space to continue that pipeline from school to helping diversify the clinical trials?
Okay, that's actually a great point. I'm sorry, your first name again was? Ricardo, great point. So I'm going to use myself as an example. As you just alluded to me. And that is, if I'm telling you about a cancer diagnosis and treatment options, you're going to be like, hey. So that's what we are doing with regards to the next generation. So we are interested in the education of the next generation of caregivers, both at the NMDP, and I also wear another hat of Chief Scientific Director of the Center for International Bone Marrow Transplant Research. So together, we're a partner organization. One's data and biorepository, the other is patient care, essentially. We are looking to build up the next generation of a diverse workforce from the physician perspective. And we're doing that with regards to having applicants get involved and then literally tutelage in terms of having them learn about the ecosystem, what they need to know, and how their role can actually benefit patients based upon their diversity. In addition to that, from a perspective of education, It's very important to educate the patient. And so that's where it gets into, I know there's got a lot of common themes here, I'm sure with BMS as well, and that's having common language that patients can understand, both in terms of layman summary for public or for clinical trials as well. So it's looking to build up the ethnic diversity into the workforce, and then it's also educating patients as well.
Can I just add something, and I'll be brief, I promise, Elizabeth. Yes, Ricardo, that is very important. You know, and one thing that I want to mention is even at Genentech, just like what you shared with BMS, is investing in the next generation of scientists, right? Even talking about, and I'm just going to use this one example with data. One of the things that we are investing at Genentech is partnering with the San Francisco State University, where we are helping San Francisco State University develop a core curriculum around big data analytics in order to train the next generation of diverse data scientists. And those students that come through that program, over 90% of them continue to a PhD. And that's how you need, as all of us here, that's what we need to do. We need to invest and be very intentional where you're investing, not just HBCUs, but your Hispanic serving institutions. Because you need to get those students early and provide them with the right tools in order to succeed.
Great. Well, thank you so much for your insight. We just have a few minutes left, so I do want to give each of you just a chance to give some closing remarks. And as you do that, maybe 30 seconds, a minute or so, we are counting down to the rest of the program for today. But think about the people in this room are people who are thinking about policy and solutions. And so what can you offer in that realm as we move on today? How about you start, Christina?
Oh, I start. Okay, I thought he was going to
We'll start on that
side. I guess if I'm thinking about policy, I guess definitely just realizing the impact of end-stage renal disease, kidney disease, how it impacts all of us. I think most people don't talk about it because it's not a happy conversation, or the type of conversation you have over coffee. But every time I tell people what I do and what I work with, oh, my grandmother was on dialysis, or my uncle died of end-stage renal disease. It is a very relevant disease in our community. So I think it needs to be at the forefront of policy changes. Again, focusing on the upstream, not just on the treating of disease, but really there needs to be funding for outreach, for screening, for education, especially in our communities. And again, healthcare coverage. I really am a big firm believer in healthcare for all, that everybody should have access, not just to, oh, you can have dialysis, yes, we'll give you this. It's like, no, you need to be able to give me dialysis and access to transplant and home dialysis, everything that everybody else has. So I do think that healthcare access and insurance coverage should be available to all our patients. Thank you.
You know, I think what you've heard from everybody from the different viewpoints and stakeholder perspectives is that we're challenging the status quo, and each organization here today, and perhaps your respective organizations, are doing what it's going to take to start to tackle the areas of health equity, diversity, and access, right? And so I would encourage all of you, as you start throughout the day, even through one of us as we're here through the day, there are best practices that we've put in place. Let's make sure we're sharing those learnings, because like we said, it's not going to be done on our own. It's going to require an ecosystem of partnerships and stakeholders all working together. Because I think in the past, we've all worked in silos, and now we're realizing we can't, if we're going to impact change within these communities and start to get that call to action and get communities to start to be mobilized and get the impact that we're looking for. So I would say, reach out to us, as we're here in the day, or others, and start to kind of engage on those lessons learned and start to keep moving the needle forward.
Veronica.
I love, Ramita, that you're building up on that partnership piece, because it truly is going to take all of us. And even for those in the room that have influence on policy. Policy is a huge piece for access. All of us in this room are patients. We'll be patients, I guarantee you, at one time or another. And if the policies are not set in place to provide access to all patients, that's going to be a roadblock. Even let's just think about mammograms. Mammograms change the trajectory of how women have cancer and cancer is detected. Let's make screening a part of what is covered for all patients in this country. So I'll end with that.
Yeah.
Great. So I think all of these themes are very important. I go back to what I said. We have to invest in ourselves as a nation in order to move forward change, especially policy. And when we think about policy, you know, that takes a while to get people on board, right? It takes a while, and I know there are staffers in the room. It's like us going to your staffer, educating you, and then you upstreaming the message in terms of your vertical. I mean, that takes time. But the last thing I wanted to impress upon you is research saves lives. There is nothing more that saves lives than research. And that research has to be accessible to everybody. Because as we know, drug metabolism differs, complications in terms of the need for dialysis, prevention screening. So research saves lives. We have to invest in research. We have to have policies to support research. And we have to make sure that we're able to provide research to those who have enrolled in clinical trials.
Thank you. Thank you so much to our panelists for this great discussion. Again, Dr. Jeffrey Aletta, Dr. Veronica Sandoval, Ramita Tandon, and Dr. Cristina Treviso. Thank you all. And of course, please keep tweeting today under the hashtag CHCI Summit. And I just want to give you a little preview. So next up are the 2 morning breakout sessions. One of them is promoting Latino heart health and what's new in heart technology. And then there is an afternoon lunch plenary titled Year 3 Reflections on Combating a Global Pandemic. So I hope you learn a lot and take back what you learned to your constituencies from this year's CHCI Health Summit. And of course, thank you again to Jose Pablo Rojas and Marco Davis for getting us started today. Thank you again.